Now that we've talked about the rheumatic diseases, and specifically rheumatoid arthritis, an autoimmune condition that affects primarily the joints, we're now going to move on to talk about the drug action of the disease modifying anti-rheumatic drugs, or DMARDs for short. These are drugs that are used primarily to treat rheumatoid arthritis, but also psoriasis and lupus. Before we begin to talk about the DMARDs, it's worth revisiting the hypersensitivity reactions that were discussed previously. There are four types, 1 through 4, where type 1 is IgE-mediated hypersensitivity. Type 2 is IgG-mediated cytotoxic hypersensitivity, which can either be complement independent, also known as antibody dependent, or complement dependent. Type 3, which is immune complex mediated, whereby antigen antibody complexes deposit in soft tissues and cause inflammatory damage. And type 4, which is cell mediated hypersensitivity, caused primarily by overactivation and infiltration of Th1 subtype T cells. Types 1 through 3 are primarily mediated by activation of the Th2 subtype of T cells in contrast. Types 1 through 3 hypersensitivity all also involve the generation of specific antibodies, whereas in type 4 hypersensitivity, the damage is caused directly by cytotoxic T cells. This next slide depicts why it's relevant to talk about those different types of hypersensitivity reactions. In these different types of immune dysfunction, a type 1 hypersensitivity is characteristic of allergic rhinitis and asthma, whereas type 2 is an aspect of lupus, type 3 is a component of both lupus and rheumatoid arthritis, and type 4 hypersensitivity is a component of rheumatoid arthritis, psoriasis, atopic dermatitis, and also multiple sclerosis. The DMARDs that we will talk about today, again, are primarily involved in the treatment of rheumatoid arthritis, but do have utility in psoriasis, lupus, dermatitis, and multiple sclerosis. This makes sense given the fact that all of those disease states involve similar types of hypersensitivity, primarily type 4 hypersensitivity, but also type 3 to a certain extent. And therefore, what you can expect from the mechanisms of action of all of these drugs is that they reduce the types of responses occurring in either a type 3 or a type 4 hypersensitivity reaction. This first video will focus on what are known as the conventional DMARDs, or the conventional agents. These are all essentially small molecule drugs that are used in the treatment of rheumatoid arthritis. The second video in this series will focus on the biologic DMARDs, which are primarily TNF-alpha inhibitors, but also include other biologic agents as well. The first drug I will talk about is methotrexate, which is really the mainstay of rheumatoid arthritis therapy and is one of the original and gold standard treatments for this disease state. The structure of methotrexate is shown here, and one of the common brand names for this agent is Trexall. Methotrexate is a drug that can be used both in the treatment of rheumatoid arthritis, but also in the treatment of some cancers. In the case of anti-cancer therapy, methotrexate's primary mechanism of action is to inhibit dihydrofolate reductase, or DHFR. However, this is not the primary mechanism by which methotrexate is anti-inflammatory. So it's important to note that methotrexate is a dihydrofolate reductase inhibitor, but this is not the primary way that methotrexate produces anti-inflammatory effects. This is because the doses of methotrexate used to treat rheumatoid arthritis are much lower than those used in the treatment of cancer. At lower doses, methotrexate has several different effects on the immune system that altogether produce an anti-inflammatory effect. The first is that methotrexate causes the intracellular accumulation of adenosine monophosphate, or AMP, which subsequently is released into the body where it is converted to adenosine. Adenosine is an anti-inflammatory molecule, so this large increase in the release of adenosine can be anti-inflammatory. Methotrexate also reduces chemotaxis of neutrophils, which is the migration of neutrophils to sites of inflammation. By reducing neutrophil chemotaxis, there are fewer white blood cells at sites of inflammation to potentially cause damage. Third and finally, methotrexate inhibits the proliferation of inflammatory cells and also the release of pro-inflammatory cytokines. In addition to being used for rheumatoid arthritis, methotrexate may also be used in the treatment of psoriasis. It is a drug that is administered orally with very high bioavailability. About 70% or more is absorbed by the oral route. There is some hepatic metabolism to active and inactive metabolites, and the majority of methotrexate is excreted unchanged in the urine. The primary adverse effects associated with the use of methotrexate are some GI upset like nausea and vomiting, and also some hepatotoxicity. Given its strong immunosuppressive activity, methotrexate can produce myelosuppression, and it is a known teratogen and should not be used during pregnancy. The next conventional DMARD I will talk about is leflunomide. Leflunomide is structurally similar to teriflunomide, which was discussed back when we reviewed multiple sclerosis treatments. The mechanism of action of leflunomide is that it inhibits de novo pyrimidine synthesis, which is the synthesis from scratch of pyrimidine bases that are used in the synthesis of DNA and RNA. By inhibiting synthesis of new pyrimidine bases, this reduces the activation of B cells specifically, because B cells are very reliant on this de novo pyrimidine synthesis pathway for activation and proliferation. Leflunomide inhibits this de novo pyrimidine synthesis by specifically inhibiting the enzyme dihydroorotate dehydrogenase, or DHODH. Leflunomide is transported into cells as the parent compound or prodrug, where it is subsequently converted to its active metabolite, which is, in fact, teriflunomide. Teriflunomide is then the active component that inhibits dihydroorotate dehydrogenase. Leflunomide's primary use is in rheumatoid arthritis. In terms of its pharmacokinetics, it has a relatively long half-life of approximately 18 hours and therefore typically does require a loading dose to get to steady state more quickly. It can produce some hepatotoxicity and is also a known teratogen. The next conventional DMARD is sulfasalazine. Sulfasalazine is 5-acetyl-salicylic acid, or 5-ASA, linked to a sulfapyridine molecule by an azo bond, which is a nitrogen-nitrogen double bond. 5-acetyl-salicylic acid is a known anti-inflammatory drug, and by linking it to sulfapyridine, this decreases absorption in the small intestine and results in greater absorption from the large intestine, which is more beneficial in the treatment of several autoimmune conditions. Its mechanism of action is essentially that it provides a topical or local anti-inflammatory action. When sulfasalazine is ingested orally, it makes its way through the majority of the GI tract before arriving in the large intestine or the colon. In the colon, the azo bond is cleaved by bacterial azoreductase found in the microbiota of the colon. After the azo bond has been cleaved, 5-ASA is then able to locally inhibit prostaglandin synthesis, producing an anti-inflammatory action in the vicinity of the large intestine. Sulfapyridine itself does also have some anti-inflammatory activity. It inhibits purine synthesis and also stimulates adenosine release, which together result in an anti-inflammatory effect. Sulfasalazine has use in rheumatoid arthritis as well as in ulcerative colitis, which directly affects the colon. In terms of its pharmacokinetics, only about 10% of the native drug is absorbed early in digestion. Once the azo bond is cleaved in the colon, about 60% of the sulfapyridine molecule is absorbed, whereas about 20% of the 5-ASA molecule is absorbed. Both of these molecules are metabolized primarily in the liver to inactive metabolites and excreted via the kidneys. The primary toxicities of sulfasalazine are caused by systemic effects of the sulfapyridine molecule. The sulfa moiety of sulfapyridine can cause some GI distress as well as some visible rashes. Finally, sulfasalazine is also known to produce some decrease in sperm count or oligospermia and can also impair folate absorption, and therefore folate supplementation is sometimes necessary. The last conventional DMARD is hydroxychloroquine, which we've heard about quite a bit this year. Hydroxychloroquine is simply a hydroxy substitution of the chloroquine molecule and was originally developed as an anti-malarial drug, but was later found to have immunosuppressive or anti-inflammatory activity. The mechanism of hydroxychloroquine is that it increases the pH of the lysosome inside cells, and especially inside dendritic cells. This increased pH of the lysosome decreases the ability of dendritic cells to process and load antigens, which subsequently decreases T cell activation. It has use in both rheumatoid arthritis and lupus, and does require several months of use for a full therapeutic benefit. Its primary toxicity is some ocular toxicity that is unfortunately irreversible, and therefore does require annual monitoring after being used for 5 years continuously. Tofacitinib, or Xeljanz, is another small molecule DMARD. It's not typically considered part of the conventional DMARD group, but it's also not a biologic because it is a small molecule, and so it sort of sits halfway between the conventional and the biologic agents. Tofacitinib is a Janus kinase or JAK inhibitor. Janus kinase or JAK is an enzyme that is important in the activation of immune cells because it sits downstream of cytokine receptors like interleukin and interferon receptors. By inhibiting JAK, the primary enzyme needed for activation of these cells, you decrease activation of several immune cells in the body, including natural killer cells or NK cells, as well as the activation of B cells, thereby decreasing serum antibodies. Tofacitinib has use in both rheumatoid arthritis and ulcerative colitis. It is administered orally, has very rapid absorption, and is over 70% bioavailable by the oral route. It is metabolized in the liver by some cytochrome P450s, specifically CYP3A4 and CYP2C19. And therefore, potential drug-drug interactions are important to monitor in individuals taking tofacitinib. Its primary toxicities are due to its ability to cause significant immunosuppression, and they are the generation of a secondary tumor or malignancy and the possibility of serious or opportunistic infection due to reduction in immune function. A similar molecule to tofacitinib called baricitinib was recently approved in 2018 and has similar activity, mechanism, pharmacokinetics, and toxicities. There are several other JAK inhibitors in development, and these will likely come on board over the next couple of years. One thing to note with these agents is that they all end in the suffix citinib, so anytime you see citinib, you can think of JAK inhibitor.